Hello, friends. It's Meg Lowry from Australia here, bringing you an exclusive interview for the Senior Rehab Project. I'm interviewing today Steve Van Andel. Still, I don't think called doctor yet, Steve, are you?
Not yet. It's in progress.
In progress, but he has submitted his PhD with great congratulations from me. And this is a guy I've been wanting to talk to for quite a while because I think his work is really fascinating. We met a couple of years at the Australia-New Zealand Fall Prevention Conference where he presented a poster about his work looking at motor control with older people. And I'm going to let Steve tell you all about it. So Steve, without further ado, welcome.
Thank you. Good to be here.
Yeah, it's so great to have this opportunity to chat and for you to share your knowledge with us because I think, to be honest, Steve, I think my undergraduate training and perhaps Australia-wide at least the undergraduate training in motor control I think is lacking compared to what I have discovered in more recent years through the literature and through attending skill acquisition conferences and things like that. And I think it sounds to me like where you're from, in your neck of the woods, your undergraduate training is a little bit more comprehensive on the topic. Would you say that's right?
Yeah, I guess so. So where I'm from, well, the Netherlands, I've done human movement sciences as a course, which kind of is set out to be a little bit less applied than some of the courses here, like physio or exercise science. But that does give us the opportunity to really go in depth in these motor control topics. And I think, yeah, that's really something we can develop the whole field in. It has some really good benefits for the applied field as well, I think.
Yeah, I think so. I think a lot of the time it's applied to sports, but certainly also in my line of work, I apply it a lot to neurological physiotherapy. But I really like what you're doing with your motor control studies in the older adult population and looking at how older people calibrate their step length. Oh, that's my Twitter feed going off. Sorry. You'll have to see, Steve, check my Twitter today. There's a group of physiotherapists in Nigeria who were celebrating World Physiotherapy Day, and they had a party and they all used the Clock Yourself app. And they put this video of them all stepping to clock yourself, and they shared it. It was so exciting for me to wake up.
Oh, that's great. Yeah. And here I was thinking that we were already trending, but
not quite, no. Not yet. Just you wait. All right. So why don't you tell us a little bit about the PhD project that you have done and the sample that you recruited?
Yeah, sure. So I think one of the interesting points is that, like you just said, a lot of this work has come from sports science or sports context. So what I really wanted to do in my project that was use those theories that were developed in sports and apply them in a healthy aging setting, because the motor control is roughly the same for everyone. I mean, sure, we're different people and with different age come different problems. But how we solve those problems and what sort of mechanisms we use for that is quite similar for everyone. Mm-hmm. So that idea we really took and tried to use in explaining some of the things that we see in older adults' gait and maybe even falls risk and falls prevention. So that's what we were coming from. So we took a theory, we took an approach that had been used in analyzing the long jump run-up, and we really literally translated that one-on-one to how we would apply that in a locomotor task in older people, which, well, probably their long jump run-up was a little bit too high to aim for, but we went a bit lower and analyzed the approach, a walking approach to step up onto a curb. But what we found is that the control of that, the motor control, and how we perceive the world around us and use that perception to guide our action, that's quite similar in those two situations, long jumping and stepping up onto curbs. So with that insight, we could see the differences in how we approach that task and how we use that perception. And we could see that as we age, we change the way we regulate our movement, and that dependence on perception became a lot stronger in our older cohort compared to our younger people that we had doing the same task, which really tells us that this, as we age and as we walk, and maybe also as our falls risks increase, we are way more dependent on that perceptual-motor coupling is what we call it. So how much we need to use our perception to define our action. And I guess that all relates to the margin of error that becomes a lot smaller in older people compared to younger people, because a fall is so close all of the time.
Yeah.
That makes sense?
Yeah, it does make sense. And it makes sense to me because I learned from you quite a lot about perceptual-motor coupling. And it's funny because you just put a name to something that I don't recall ever having learned the name of it. But obviously the principles apply to, to so much of what we do in train in motor learning, especially in the neurological population, I guess. But perhaps you can explain to our audience perceptual-motor coupling and all of this steep learning curve I went on. We probably can't go into great detail, but about affordances and action capabilities. And the great way, guys, that Steve explained this at a conference that I attended, a skill acquisition conference at ACU, he used Mario from like the Super Mario Brothers to demonstrate how Mario decides whether or not he can jump a gap, like a gap in a cliff or something. And it was awesome. So I know you don't have the picture in front of you, so it's not quite as good, but could you perhaps explain that for us, Steve, so that the people in the audience can picture Mario and jumping over the cliff and they can understand where you're coming at, where you're coming from with all of this?
Yeah, sure. I mean, I don't really think we need the picture for that, because Mario is so familiar for everyone that I'm sure that everyone is picturing him right now standing in front of a gap and thinking, can I jump this or not? And that's really one of the core questions that we, with this perceptual-motor coupling research, try to analyze. What actions can you perform and how do you know whether you can perform those? And that concept that you mentioned, affordances, is a really big one in there. So affordances are the things that we perceive in the environment that define, yes, this is a gap I can jump, or it isn't. And similarly for older adults, this is a curb I can step onto, or this is a curb I can't step onto, or one that I can step onto, but I need to regulate that really carefully. So in the theory, what that comes down to, if you picture Mario there standing in front of a gap, then we usually straight away know whether that gap is jumpable or not for Mario, because we've played a lot with him and we know what his capabilities for jumping are. Mm-hmm. So this experience in using action capabilities, in walking and running around with Mario, in jumping around with him, gives us the experience to analyze whether that gap is jumpable. And the great thing about video games is that they never put a gap in there that isn't jumpable, because that would make a very frustrating video game. But just imagine if we make that gap bigger and then Mario needs to reassess whether the gap is still jumpable. So if we have a gap that is 1.5 times a regular gap, can he still jump it? And the only way to know that is by experience and by practicing that jumping and seeing what our jumping capabilities are. And maybe Mario will find that he can't jump that second gap because it's too big. So then we've had
the magic mushroom, right?
Yeah, so then we come to changing action capabilities, and we can give Mario this magic mushroom, and he'll grow, and suddenly this gap that wasn't jumpable before now becomes jumpable. So again, we need to experience that. We need to figure out these new action capabilities for jumping, and then adjust our decision-making or affordance perception to these new action capabilities. And the same, or I guess the reverse, is what happens with older adults, where as we age, we lose action capabilities and we become less flexible and less strong. So we need to recalibrate and keep experiencing our new and declining action capabilities to make sure we're accurate in our decision making.
Yeah, and I guess a lot of the time, I mean, bring it back to the patients that I see, like I might see somebody with very poor strength in the legs, very, a small step length and reasonably poor balance, and yet they're safe to walk in their home, or sometimes safe to walk in the community, because they're cautious and they're very in tune with their own action capabilities. So they know their limits of stability, and they know what they can and can't achieve, and so they rarely fall, because they're very cautious about how they navigate their environment. Whereas you might see somebody else who's got twice as good a leg strength, a better stride length, and greater balance, I guess, or even better reaction times, but they're more likely to fall if they don't have that same insight into their action capabilities. So to know their own limits, and the insight is everything. And I'm always saying the brain is king, but I think there's a whole lot there that we don't understand about how cognition changes somebody's own insight into their abilities, or how you might even perhaps lose or forget sometimes your action capabilities, so your body's limits and capabilities, when you haven't practiced it in a while, such as after a prolonged period of hospitalization. And perhaps that explains why part of why we see so much higher maybe 10% higher rates of falls in the post-hospitalization, so the post-hospital discharge population, but like 50% greater injuries in those populations as well. Because, I mean, I like to put it down to saying they haven't practiced walking in their home environment. They haven't used their body in different ways. So I think that in some ways, and maybe with the new medications on board, they forget a little bit. They don't have that recency of memory of their action capabilities, and so they're less able to judge what to do and less able to use their bodies in a certain way when they do fall. Like, do you think this is a big extrapolation of what you're studying, or
I think absolutely. I mean, our data that we collected in healthy older adults, obviously we can't say a lot about post-hospital settings, but the theory is quite strong there as well, I think, because it's a double-edged sword in that way. Like you said, if you're in hospital, you're not active, you can't explore your capabilities, so you can't adjust to them. But also that period of less activity and maybe some surgery or something, that's really going to affect your action capabilities as well. So that's really like eating a magic mushroom, if we stick to Super Mario, in having a quite rapid change in action capabilities as well. So a quite rapid decline when we're in hospital, which makes that calibration, that updating of that idea of our own capabilities all the more relevant in that period after the hospitalization. I think really that the physical activity there could be key in preventing falls post-hospitalization, because we just need to recalibrate our action capabilities to make that decision making go safe again. Like you said, a small step length has never killed anyone. That's not going to make you fall. But taking small steps and not being aware of your boundaries, that will make you fall. So that's I guess where the interest lies in these sort of theories.
Absolutely. And even just going further from that, I think what's really interesting is when somebody improves their action capabilities, such as after a period of physical therapy, exercise therapy, and they, when there's that mismatch between what their body can do and what they think they can do, even when they've actually improved their abilities, sometimes they're still more likely to fall as well. Particularly in the institutionalized setting, in the SNF setting, they call it in the USA, or the residential care setting here. If you improve somebody's physical mobility on the I think it's PMS, the physical mobility scale, it shows that it increases their risk of falling sometimes. And it's probably just that their boundaries and their limits change, and they're less in tune with that. And even going on from there, Steve, because I was super fascinated with a presentation I saw. I think it was actually at that conference we were both at, the ANZFP one, the fall prevention one. It might have been Jasmine Menant, Dr. Jasmine Menant from Neura, who presented on what was it? Oh, changing people's vision, like, so improving their vision by like improving their refractory, what's it called, refractory index or something. So when, like, basically giving them glasses that are appropriate for their visual impairment, and how they would expect that would improve their mobility and reduce their falls risk, but it actually did the opposite. Like, it increased it by like 50%. Yeah. Even when they corrected their vision, because I guess in some way previously when they had poorer vision, their brain was compensating and correcting in the background to achieve the right outcome, motor outcome, and then it was still applying that same code that it was previously applying to a change in the vision, like to an improved vision, and then the outcome was then not quite well calibrated for the environment. Like,
so what we see in that calibration research as well is that for older people it takes a little bit longer to achieve that. So if we make a very rapid change to the system, then older people need a little bit more time to adjust to that, a little bit more experience, a little bit more exploration with this new system. And if we haven't done that completely yet, then the margin of error becomes bigger, and we're more inclined to make movement errors like falls. So I'm happy you bring that up. There's a couple of research studies coming out now as well, really going for a functional approach to rehabilitation, for instance. But there's a couple of different fields where they apply that. Because what we used to do in falls prevention as well, I think, is really focus on improving on risk factors. So we take one risk factor, we improve on that. So we're going, for instance, into strength training in the legs, and that's all good, and our legs become stronger, and theoretically that should reduce our falls risk, because, well, low leg strength is a risk factor. But then we see that it might not be as effective as we think. And that's all related, I would think, or following these theories, to the fact that we're improving one system and not adjusting with our entire one. So we're improving one subsystem, but we're not adjusting with our entire system. Yeah. And therefore we should prompt a more functional approach, and not only do strength training in a gym, but also bring that to the actual setting where it's relevant. So make it more representative of the situation where people would actually find themselves falling. So next to that strength training, I would also always say do some sort of walking activity, so you know so you learn how to use these new action capabilities in the control of things like gait and other functional tasks. So we need to adjust. We need to translate those new skills, those new found strengths, maybe, to those functional tasks. And that would be, I think, a really beneficial way to look at things like falls prevention, but also a lot broader context, I'd say.
Yeah, sure. Before we go on and explore your study, which we really got to get into, while I brought that up, I thought I just cited a study then, and I can find it straight away because I knew where it was here on my phone. So it was Cumming et al. 2007. If you guys are interested in that one, they recruited 616 older people. The intervention group received a comprehensive vision and eye examination by a study optometrist, and a bunch of them got new glasses to improve their refractory error. And they increased falls by 50% by improving their vision, correcting their vision. And then there's another study also worth looking at, Chapman et al. 2011. They only had 10 young people and 10 old people. And basically in their study, what they did was they looked at changing the lens magnification. Like, so they had glasses and they changed the lens magnification by 1%, 2%, up to 5%. And they found that gait adaptive changes mirrored the effect of lens magnification. So when we do give give people new glasses, we need to warn them on the effects of that changed refractive error when they first get that new pair of glasses, because they're actually at a greater risk of falling just by correcting their vision. Fascinating stuff. So, all right, let's go into now to your study with the calibration of the step length and looking at how older people might step up onto a curb. Yeah, so tell us, who did you had younger people and older people in your study, am I right?
Yeah, so we invited about 20 younger participants and over 100 older participants of 60 plus, to both be able to analyze those age-related differences, as well as later on follow the older participants prospectively and analyze their falls incidents. And well, like I mentioned before, we really use this paradigm that's similar to a long jump run-up, in which we look at the error in any given footfall in the approach to a curb, and then see if the following step length is dependent on that error in the previous foot placement. And what you expect to see then, if people correct the error, then if your foot placement is, say, 10 centimeters back from where it normally is, then you would expect a 10 centimeters longer step following that to account for that error. So that's what we looked at and assessed the relationship between these expected adjustments and the adjustments that were actually made. What we found in the long jump and also in our task here is that as people get closer to their target, this relationship becomes stronger. So we're more dependent on our perception of that error to produce the next step lengths, to produce the next action. And as we get closer, that becomes stronger. But what we also found is that as we age, this relationship becomes stronger. So the aged cohort, the older adults, and also within the group of older adults, which spread about 25 years, I think we had. Also, the older ones of those seem to make that adjustment stronger compared to the younger ones. So that's an interesting.
And did you expect that? Because I wouldn't have originally expected that. I think when I met you at the conference that we first met at, and you were presenting your paper, you didn't have those findings yet. And I guess I had hypothesized that the older adults would have poorer coupling. Well, I mean, yes, I'm going to say poorer, but like a less strong coupling with their environment.
Yeah, absolutely. That's the interesting thing. Well, we kind of went into this study with blank expectations because it's not something that had been done ever before. But yeah, what you expect is stronger coupling to be better. It's a more controlled movement, and better. You expect to find that in younger people, or similarly in the non-fallers compared to the fallers, and that's exactly not what we found. So that was quite a hard thing to wrap our heads around when we first saw those results. In the end, though, I think it makes sense as well if we look at it from that action capabilities perspective. So if our action capabilities decline, then we will need to produce a more controlled movement, because also our margin of error becomes smaller with that decline in capabilities. So it's not, like you said, it's not like the younger people behaved better or worse compared to the older people. It's just less strong coupling in young people and more strong coupling in older people, which basically just resembles the fact that that's the coupling they need to make. That's the motor control they need to use, the regulation they need to use in order to do this task safely.
Right. So for somebody who's got good balance and a good stride length and good reaction time and good strength, then near enough is good enough when they're going to step up onto a curb. They don't have to calibrate to the nth degree because they've got enough of reserve, I guess, physical and flexibility and agility reserve to cope with whatever the outcome is within a certain within a certain buffer zone. And the older person, it's like a lot more make or break for them. Get it right, because if you don't get it quite right, you're not going to have as much backup.
Exactly. And this is where it gets really interesting, I think, because what we did is, of course, a really easy task. We had people walk for 8 meters and step onto a curb. And, well, most older adults are still able to do that fine. We didn't have anyone falling in our lab, which is a good thing. But that the fact that already in such a simple task, older adults need to show this stronger regulation and show so big differences from younger adults, shows us that what would it be like then in the real world when we go out of the lab and we do these tasks like crossing a street, stepping up on a curb, whilst watching out for traffic and not running into other pedestrians and carrying some shopping bags or
speeding
whatever.
up because the traffic lights guy has turned from green to yellow, and you've got to hurry up. So you've got to make a faster gate speed as well. And
So what we detected is that in a very simple task, older adults already need stronger regulation and this stronger perceptual motor coupling. We reason that if we make the task more difficult, like it is in the real world, then it's harder to produce that stronger regulation. And that might be one of the factors, at least, that could lead to the higher falls incidence in older adults.
Which leads us to think, that when we're training, like I do a lot of obstacle course training. I do a lot of I make up obstacle courses in people's hallways, especially when I do home visits, and in my balance classes, I put out obstacle courses at different times. And now I guess I think about it more. I can put the words to it to say I'm training their perceptual motor coupling. I'm training their agility giving them more reserve or more ability to sort of negotiate and navigate different environments and different requirements of them at different distances and different heights. And I think we already know that this is good, but I think you're really nutting out the why for us. It blew my mind. It blew my mind, Steve, when I saw those results from that study. So, and I think it's studies like this where the outcome is different to what you expect that really helps to make you a better clinician and a better clinical reasoner. And I think, so far, guys, we've talked about younger people versus older people in terms of these subgroups. But would you tell us a little bit more about what you found? Because you said before it was a prospective study, so you looked at their falls incidence over the next 12 months. So tell us the difference in perceptual motor coupling between those who fell and those who didn't fall.
So in a large part of this task that we did, there were no differences between these two groups. So in the approach to step onto the curb, we found exactly the same values in coupling for the fallers and the non-fallers in our cohort. It was just that last step that led from the ground surface onto the curb where we did find differences, and the fact that for fallers that step was even more demanding, that they needed to produce an even stronger regulation in that step than for the non-fallers. So again, still quite a simple task, stepping up onto a curb, but for fallers that proved more challenging than for non-fallers, which really I think reinforces that idea of needing to train this perceptual motor mechanism so we can enable people to produce that in any given situation, and not only just in our lab here. But I guess that's a translation that we'll be making in the next couple of studies that we'll be bringing out.
Absolutely. I can't wait to see what more you produce along this line of thought. It's just, to me, it's fascinating. My head's ticking over at 100 miles an hour still, just just thinking about it. It's just, it's really interesting how multiple systems interact. I mean, we know that staying on your feet, it's not purely about balance in the vestibular system. We know that there's a lot of different systems that are involved, and I think motor control has always been one of those systems that we've considered, but when you define it in this way and you look at perceptual motor coupling in and of itself and how it is used as a strategy to compensate for what appears, what you can expect to be from these results. I mean, you don't know for sure, but poorer performance of other systems that are contributing to the falls in these people.
Yeah, it's always that balance that we have, that if we decline in one aspect, we need to recalibrate that whole system. We need to relearn how to work with our entire body, with the entire movement system. And I think, yeah, we're just looking at one example of how people do that. But the theory goes in any movement and in any system. And yeah, that way it's quite strong to analyze aging, I think.
Yeah, absolutely. That's fascinating stuff. Thanks so much for sharing it with us. Before I wrap it up, I just want to ask: is there anything else you have studied or learned, or any words of wisdom or light bulb moments that you've had in the past that you think would be, worthy of disseminating to a broader physiotherapy audience?
Wow, that's
I threw that at you without telling you I was going to ask you that.
Yeah, and that's a big question. I think we nicely touched on some of the main themes of what I'm doing and what I'm into with my research. The push towards a more functional approach to healthy aging, a functional approach to falls prevention, I think is really really important. We need to stop looking at these individual parts of the system, looking at age as a number, for instance, but look at the system and how the body is able to move in a given situation. And then to me, it doesn't matter whether it's the leg strength that's giving away, or the vestibular apparatus, or just eyesight. It's the combination of all of those together that makes us fall or not. So that's also how we need to analyze that, and how we need to train people not to fall by training that entire perceptual motor system, which basically just means the movement system, because you always use perception and action, I would say. So yeah, that holistic approach, functional approach to learn how to do these things in the real world, I think that's really key to solve some of the problems that we face in gerontology at the moment.
Thank you so much for illuminating that for us so well, so clearly. And I think every time those of us listening go on and do another dynamic gait index, and we've got that shoebox or that box that they have to approach and step over or step around, we'll probably think of this particular podcast episode and perhaps analyze their perceptual motor coupling in a new light, from a new angle, as a strategy that can help to compensate for other systems that are perhaps underperforming in a faller. So thanks so much for your time, Anne. I really look forward to seeing what else you produce now in your postdoctorate work, and keep in touch.
Yeah, will do. Thanks for having me here. This was great.
It really was. All right. Thanks so much. And SRP people, stay active, stay in the Facebook group, and shoot me any questions. And I'd be happy to. I think what I really want to do is get on and start talking to a few more researchers whose studies have found something that is almost contradictory to what we would normally expect, because it's those sort of mind-blowing outcomes that we don't expect, that I think we stand to gain a lot from. So keep listening in, and I'll try to chase down a few other fall prevention researchers who have found things that we did not expect to find, and we'll pull them apart in detail. Thanks very much, Steven Van Andel. Have a great day.
Thank you. You too.
Bye.